Let's welcome Ciaran McGarvey, who's joined us from London, to tell us about our graft choices, and let's see if what they're doing in Australia is good.
Good morning. Thank you for the opportunity for speaking this morning on the choice of graft in multi-ligament injury. Multi-ligament injury is a vast umbrella term, and there are multiple variations. So I can't, I'm afraid, give you a single answer of what's best for every possibility. But we can go through some of the histology, the mechanics, and the outcomes to help guide you to what's best. Before we consider the individual grafts, we have to think about some other factors that might influence what you do and what graft you choose. The age of the patient, you might not want to use bone blocks across an open physis. In a short patient, you might be worried about the length or diameter of your hamstrings. And you need to think about what the patient wants to get back to. If he kneels, you want to avoid giving him something that gives him anterior knee pain. If he's a sprinter, you might want to avoid decreasing his hamstring power. If he's a jumper, you might want to avoid weakening his extensor mechanism. And of course, the patient may have some ideas about what he wants. The type of injury will influence things, the number of ligaments that you need to reconstruct within the tourniquet time available. Is the PCL injured? You might not want to defunction the extensor mechanism, which is the main agonist to the PCL. And is the injury acute or chronic? If you're thinking about a graft that requires some ingrowth from native tissue, you might not want to be using that in a chronic injury without a viable stump. You will need to think about yourself as well. If you've got to do 4 ligaments in 2 hours, you need to be familiar with the ligament you're choosing. It needs to be cost effective, and it needs to be available. So what's out there? Autograft, from the injured knee, the other knee. Allograft, either from cadaveric sources or sometimes from living donors. Synthetic grafts, and on the horizon, but not quite here yet, Xenograft. So the ideal graft will need to have a number of qualities outlined there. It wants to reproduce the biomechanics and histology of the ACL. It wants to incorporate quickly and strongly into the bone tunnels. It wants to be a safe and reliable harvest, cost-effective, readily available, and no risk of disease transmission or rejection. Amongst the autografts, bone patella bone was probably the first used. In the US, it's probably still the most commonly used and is held up as the gold standard. It's harvested through a midline incision and yields a tendon with bone blocks at either end. You know what you're going to get. You can harvest a graft of about 1 centimetre in length. Those are reliable, and you've got bone blocks at either end for incorporation into your bone tunnels. Unfortunately, there are some downsides. Anterior knee pain is estimated about 17%, although some people will argue as to whether that knee pain is actually a significant barrier to function. But it is a problem in patients who kneel a lot. The patient has a larger incision. You may get some weakening of the extensor mechanism, and in rare cases, there have been some patella fractures. Hamstrings are probably now more common in Australia, in Europe, and from what I've seen in South Africa. They're harvested through a smaller incision over the pes anserinus and yield a tendon that's usually folded double and inserted as a 4-strand graft, including both semitendinosus and gracilis. The benefits: you minimize that functional deficit, the anterior knee pain, the kneeling pain, although functional deficit can be a problem in sprinters, and you have a smaller incision. The main issue is that you don't know where you're going to get until you've got the hamstrings out. You don't know how long they're going to be, what diameter they're going to be, and there's always a risk of amputation. The saphenous nerve is close by, and there is incidence of numbness both on the medial side of the leg and also laterally with the infrapatellar branch. There's a small chance of damage to the MCL. And as we'll see, biology and biomechanics suggest that there is slower incorporation into the tunnels and the possibility for elongation. Quadriceps is being used a little bit more frequently now. It yields a graft that has 3 layers, which then fuse to form a single layer, and it can be harvested with or without the patella bone block. It has all the advantages of the bone patella bone. It's a reliable harvest, and actually compared to bone to patella bone, you can get more cross-sectional area inside the joint, and you leave a greater proportion of the tendon behind. The disadvantages, similar to bone patella bone, you defunction the extension mechanism, and there is a possibility for greater post-operative pain, with a possibility of catching some of the synovium as you stitch back together the donor site. This chart looks at some of the biomechanics of those autografts and some allografts also, and all of them have ultimate tensile strength and stiffness which is better than the native ACL. The problem with that data is that's day one data. What happens inside the joint is slightly different, as shown on the graph on the right. And in fact, the graph on the right is slightly optimistic in that it has the graft strength returning to 100% of what it was when it went in. Noyes in 1989 in a monkey model showed that at 7 weeks, the ultimate tensile strength and the stiffness of a bone-patella-bone graft had dropped to less than 25%, and those had recovered to nowhere near 100% by a year. This is because of the graft healing mechanism. The graft itself needs to undergo a process of ligamentization, where the host cells are replaced, the donor cells are replaced by host cells, and the graft needs to incorporate into the tunnel. The picture on the left is a histological specimen. A shows a tendon with very clearly defined margins between tendon and bone at 6 weeks. At 6 weeks, however, in a bone-patella-bone graft, you can see that the bony block is already starting to incorporate into the host. So the recognized figures are that a bone-patella-bone graft will have incorporated to the tunnels at around 6 weeks, hamstring autograft at about 10 to 12 weeks, and allograft may take up to 24 or 36 weeks. However, when Tonita looked at a dog model, ACL reconstruction, and compared pull-out strength of bone-patella-bone versus flexor tendon, he showed a difference at 3 weeks, but not after 6 or 12. So how do they do clinically? I'm slightly hesitant about putting up a meta-analysis after the last talk, but this is a meta-analysis from the knee published last year, and they looked only at randomized controlled trials and high-quality comparative prospective studies. Follow-up was between 24 months and 132 months. The headline figure was that there was no difference in failure between bone-patella-bone autograft and hamstrings. However, there are some subtleties beneath that. In terms of return to pre-injury, bone-patella-bone did better. And in terms of stability, bone-patella-bone did better on both the pivot shift analysis and instrumented laxity on the KT1000. The downside was that bone-patella-bone has significantly more knee pain and also a trend towards a significant difference in the loss of extension of more than 3 degrees. The problem with meta-analysis here is that it masks a variety of techniques, and particularly what tunnel on the femoral side was used and what type of patient they were put into. These are some results from Andy Williams, published last month in the British JBJS. And he described his change in technique from a central anatomic position to an anteromedial position, and his change between bone-patella-bone and quadrupled hamstrings. And he showed that while overall there wasn't a huge difference, the bone-patella-bone performed much better when he used the central anatomical position. Allograft comes in all shapes and sizes, with bone blocks, without. Achilles on the top left, bone-patella-bone below it. And on the right-hand side, semitendinosus, which is available, but not used as often as tibialis anterior or posterior, shown bottom right, which is longer and thicker. It can be taken from living donors. Leo Pincheski in Australia had a series of 30 in which parental hamstrings were harvested for use in pediatric patients. And an Indian group published a series of 3 in which they used maternal hamstrings for PCL reconstruction. Cadaveric, though, is the most common, and the big issue is gamma irradiation. So in order to eliminate bacterial spores, you need 2.1 megarads, and to eliminate HIV, maybe 4 megarads. The problem is, over 2 megarads, you affect the biomechanical properties. You get increased elongation, reduced stiffness, reduced ultimate tensile strength. Less than that may not affect the biomechanical properties, but may not clear out the bugs that you want it to. This is reflected in meta-analysis also. So this is a meta-analysis from Arthroscopy published this year in which they compared for ACLs, autograft versus allograft, without distinguishing between irradiated and non-irradiated. And you can see that autograft was favored by almost every measure of function. However, in a meta-analysis from last year published in the knee, ACL autograft versus non-irradiated allograft, you could see that there was almost no difference. And in fact, allograft performed better on the lysome functional score. That was for ACL. For PCL, not quite so much data available, but this is a study from 2015 comparing 4-strand hamstring versus tibialis anterior for PCR reconstructions using a transtibial technique. Groups were well matched. They only had 2-year follow-up, but what was encouraging is that the tibialis anterior allograft was thicker, and when subjected to instrumented and clinical laxity measures, they found that it did better, with 1 millimeter less translation on the instrumented laxity and achieving a grade 0 posterior draw on 8 out of 19 in the allograft case versus only 3 out of 18 in the autograft case. Synthetic grafts have a pretty checkered history. They were first tried as far back as 1918 with some silk sutures, but they all failed. The 1970s and early 80s, carbon fiber grafts became popular. Again, they almost all failed and led in particular to a lot of synovitis. As these grafts broke down, they generated carbon wear particles, which caused effusions in these patients. So moving away from carbon fiber into the 1980s and 1990s, moved to polyethylene and polypropylene woven or braided structures. And what characterized these was often a study at 1 year saying how well they were doing, and then a steady trickle of studies at 3 and 4 years with failure rates of up to 33% in the case of Gore-Tex and up to 47% in the case of Dacron fibers. What characterized those polyethylene and polypropylene implants were they had a woven or braided structure. The transverse nature of the fibers in that woven structure in the interarticular portion was thought to be a problem because it didn't stand up to torsional or shear stresses. So they broke down, they generated wear particles, and as shown in the histological slide on the right, those wear particles then started popping up in lymph nodes distal to the knee. So LARS it's called a new kid on the block, but it's been around since 1990s. It had an explosion of popularity in Australia with its use in some rugby league athletes. So it's made of the same material that the Dacron was made from in the 1980s. What's different about LARS is that its intra-articular portion only has longitudinal fibers. The woven piece is meant to be kept inside the intra-articular tunnel. The other key thing about LARS, which is mentioned in the OPTEC, is that they must have a viable ACL stump in order to encourage tissue ingrowth into that material. So how does it do? This is a systematic review from Julian Feller, published last year on Arthroscopy. The problem with it is that the quality of the studies are not great. So in LARS ACL, there's only one randomized controlled trial, and LARS PCL, there were none. Follow-up, however, was up to 8 years in some cases. And the results, with those caveats, are encouraging. So compared to the Leeds KO, the Dacron, and the Gore-Tex below with failure rates of between 16 and 33%, the failure rate for LARS ACL was only 2.6% in this study, and the failure rate for LARS PCL only 1%. A note of caution, however, comes from a study published this year from some Greek military recruits, where they found at 9.5 years a re-rupture rate of 31% in LARS ACL. So scratching their heads as to what could be causing that, they looked at the age and activity level of their patients versus some of the other studies that had been published. And they found that in the studies with the lower re-rupture rates, so Cerulli with a re-rupture rate of 0% and Parchi with a re-rupture rate of 4%, they were being performed in much older patients with a mean age of 46 in Cerulli's paper. So that leaves Xenograft. Xenograft has a lot of potential advantages. Compared to Autograft, there's no donor site mobility. Compared to allograft, it's cheaper, it's more abundant. And compared to synthetic grafts, it may have better biomechanical properties and no risk of the synovitis. It does have issues, however, and the main one really is to do with tissue rejection and antigenicity. And in discussing that, the buzzword is alpha-gal. So about 80 to 90% of genes are shared between cows, pigs, and humans. The problem is alpha-galactosidase, which is found, it's a carbohydrate on the cell surface in non-primate mammals. And unfortunately, the most common immunoglobulin in primates is anti-alpha-gal. If you implant it, you get an immediate antibody-mediated rejection. So they did develop some pigs that had that gene knocked out, but the biggest development in terms of making xenograft a possibility has been the possibility to enzymatically degrade the alpha-gal on the surface of these cells. So compared to synthetic grafts, xenograft history is even worse. Prof. Amos and Prof. Heatley in 1987 and Dalsted in 91 tried cow xenograft with very high failure rates. But the future may come in the form of something called ZLIG, which was reported this year by Zaffagini from Bologna in Italy. This is a commercially available xenograft, which is subjected to a commercially patented process for degrading the amount of alpha-gal on the surface of those cells. It's been tested in monkeys, and when implanted in 2007, in 10 patients, they found that of the 6 they followed up, 5 were still stable at 2 years. There were no alpha-gal, anti-alpha-gal antibodies immediately, and the anti-non-gal antibodies returned to normal after 12 months. They have done a randomized prospective trial, which does have 2-year follow-up, but interestingly, the results haven't yet been published. So that's very much wait and see. So in summary, I think probably allograft is the most reliable alternative to autograft at the moment. LARS is a useful addition, but I think it requires patients to be done acutely. And xenograft, no comment. Thank you.
Thank you, Ciaran.